So do you have any insight into like how colonoscopies, the removal of the microbiome and the replenishment of the microbiome interact with each other?
The composition of your diet impacts the composition of your microbiome. If you were going to make a dietary recommendation and say, stop eating red meat because it's bad for you, well, then the question is, well, what are you replacing that with in your diet?
Dr. Char, I'm done with active treatment. What in the world do I eat?
So I usually recommend...
Welcome to The Patient from Hell. Today, we're diving into the world of survivorship with Dr. Sara Char, a clinician and researcher from Dana-Farber. We explore some incredible topics. We talk about the microbiome and colon cancer, survivorship care planning, what constitutes a healthy diet, the difference between a Western pattern diet and a prudent health diet, macros, GLP-1s, and fatigue. And of course, we also cover mental health in the survivorship population. Dr. Char, can we maybe start with just a question about you personally? Where and why did you join oncology?
That's a hard question, actually. I have thought about this a lot because sometimes when we think about our narratives and our CVs, it reads like it was a 10-point plan that you had all along. Like I liked the science thing, and then I went to medical school, and then I became an oncologist. But I think the truth is that I've always really been interested in cancer biology from the first time that I ever learned about it in high school and was exposed to it. And I think that interest is what academically drew me into biochemistry in college and then took me to medical school. But sort of at the same time that I was having this academic journey, I also had a personal experience in my family with cancer. My aunt was diagnosed with stage 3 colon cancer when I was in high school. She had surgery, chemotherapy. She had a brief period of remission, but then her cancer recurred. And ultimately she passed away when I was in my first year of medical school. So just seeing my aunt go through that and the impact on my family as well, I'm sure that even though I don't think I set out to be an oncologist or set out to be a colon cancer doctor, which is what I am now, that unconsciously it definitely influenced me.
Can you tell us more about the first time you learned about cancer biology? What do you remember?
I think I remember just learning how cells have this intricate system of regulating growth. Like they have these programs that tell them to grow and heal wounds. And then they have these intricate programs that says enough is enough. You need to just calm down and be a cell now. And how easily that can be perturbed and become a cancer. There's just numerous ways that it could go wrong. And I remember like the first time someone was like, and that's where cancer comes from. I was like, wow, that is so interesting. And if it's really that simple, like why have we not sorted this thing out? And then as you go on in school, you just learn more and more about the complexities of biology.
I imagine that high school was maybe a few years ago.
Yes.
And the reason I asked that question is from my very naive understanding, our biological understanding of oncology or cancer cells has evolved so much in the past 10 years, 20 years. Maybe we can start with like, what has surprised you about like a recent learning that you've seen in the world of cancer biology?
I think that this is probably not surprising to people who are way smarter than me in the field, but I think as I was learning oncology, through fellowship, like I think that the focus that I had has always been on the actual cancer cells and how they grow and how they evade, our best treatments. And now it's just, I feel like it's become so much more complex. It's about the immune system and the microenvironment and the way in which the tissue that the cancer grew in supports its growth or doesn't support its growth. Even in colon cancer, for instance, we know that metastases in the liver act very differently than metastases in the lung. And it's not just the cancer, right? It's the organ that it ends up in that impacts its biology. And so I think that had been very surprising to me learning about cancer.
I actually didn't connect those two things. That makes intuitive sense, but in retrospect,
I mean, I didn't really know that until I started seeing patients and treating patients with colon cancer.
Fascinating. Can you talk a little bit more about the microenvironment for colon cancer? Because I feel as though microenvironment, and I'm going to use another word there that may or may not be related, but the microbiome of the gut. How are those two things related in the world of colon cancer?
That's a huge emerging field and something that, as you alluded to, we really did not know very much about when I was in high school, for sure. And so the gut microbiome is really, we think, important in the development of colon cancer because, I mean, the inside of our digestive system is really open to the world. It's from end to end. It's not a sterile environment. It's full of bacteria. Everything that we eat and ingest goes into the colon eventually. And all of those bacteria live a very complex life. We're learning more and more about it, the ways in which they interact with each other, the ways in which they interact with what we eat, digest the things that we eat, then create compounds that can potentially be protective or potentially be inflammatory to the gut. And we're learning more about how those things might contribute to the development of colon cancer. And then we know of even less about this, but starting to learn more about how they might interact with the colon cancer as it metastasizes and what the role of microbiomes might be in development of liver metastases, for an example.
At some point, probably a different episode, I would love to dive into this with you because I think it's one of the things that in the world of like nutrition meets patient in treatment, meets colon cancer, meets like, there's just so many intricacies there that I imagine that as we learn more and more, the protocols we're giving patients, both during treatment and post-treatment, I imagine are going to start shifting even more than they are right now.
It's just so complex, right? It's like we know that the composition of your diet impacts the composition of your microbiome on a short term. Like if you just decided to eat only kale for a week, the different diversities of the bacteria in your gut would change. And then if you decided to eat only red meat for a week, similarly, we know that if you emigrate from one part of the globe to another and adopt the diet of the place that you end up, your microbiome will more closely resemble the people around you than where you came from. But on a longer term, which is where we think, it's exposures over time that lead to the development of colon cancer, how diet may be influencing the microbiome over a longer period is a little bit less clear. But we know that it's highly responsive to what we eat.
I'm preventing myself from going down this rabbit hole. But I would love to put a pin in it and maybe if we have time, come back to it because I think it's such an important area and I imagine relatively understudied actually compared to other parts of cancer biology.
I think, there's a lot more people exploring it, but there's still a lot to be learned.
Dr. Char, so on that note, hard pivot, can you tell us about the study you read for us? Just high-level overview and maybe what you learned from it.
Yeah, so we'll transition totally. This is a whole study about cancer survivorship. So, when patients are going through active treatment, there comes a point when that treatment ends and then they're on surveillance where we watch them closely to see, if their cancer is going to come back and to make sure that they're doing okay from that perspective. But survivorship really encompasses a lot more than just surveilling patients to see if their cancer comes back. It's the whole experience of what that cancer has done to a person's life, to their biology, physically, mentally, and to their caregivers and loved ones. But this study in particular is looking at what happens in this transition point when people transition to survivorship care. And it's looking at the modes of delivery of survivorship care plans. So a survivorship care plan is essentially a personalized guide that is given to a cancer survivor that details the follow-up care that they need, the potential long-term treatment effects that they should be on the lookout for, advice on healthy living. And, the American Society of Clinical Oncology provides guidelines on what should be included in the plans, but then a person's provider will then tailor it to what makes sense to that particular patient. So we know that these are really helpful in helping people navigate survivorship care, but what the best method of delivery of these care plans is not yet clear. So that's what this study was looking at. It was a randomized controlled trial. They wanted to look at 3 delivery methods for plans: mailing the plan, an in-person office visit, or 2 in-person office visits. And they were looking at people who had been treated for stage 1 through 3 breast, prostate, or colorectal cancer. They randomized them to one of these 3 methods. They followed them for 18 months, and they wanted to know what was the proportion of patients in each arm who received all of the recommended care that was in their plan during that first year of survivorship. So really, it's like which method helps people adhere to all aspects of survivorship care.
And what did the study find?
It was actually really interesting. I went into it with some preconceived notions. I was thinking, well, if you had two office visits where it's like more face-to-face care, you are more likely to adhere to all of your care. And it turned out that actually all the methods were the same. There was no one method that was superior to another. And they did a bunch of different subgroup analyses. So they said, well, among all the breast cancer survivors or prostate cancer survivors, is one method better than the other? And the answer was no. They also had done this study across two very different sites. One was an academic medical center in an urban center, and another was a more community-based medical center in a rural area. And even among those two populations with those two different kinds of resource settings, there was no difference in adherence to care with these three methods.
Why did that surprise you?
I mean, I thought that having more visits would provide more opportunity for a discussion, a back and forth. And also with the two visit method, they had people come in initially and then they had them come in again 6 months. So that I would have thought that would have been a prime opportunity to troubleshoot. Like, oh, I tried to make this appointment. I couldn't get scheduled. Like, let's help you get it scheduled. Or, oh, I didn't realize this was important. Why should I do it? Let's have a conversation about it. But it turned out that it didn't really matter. So I found that surprising. I also thought it was surprising that among the different types of survivors, so breast cancer, prostate cancer, colorectal cancer, there was really different types of, or different levels of adherence. So in the breast and prostate cancer survivor groups, it was like 50% roughly of the group that had complete adherence. Whereas in the colorectal cancer, among the three arms, it was roughly 25%. And as someone who treats colorectal cancer, that really struck me. I was like, what is the reason for that?
Any hypotheses there?
Initially I thought, well, maybe there's got to be differences in the types of survivorship care that is recommended. And actually, when you in the paper, they put this really nice table there that details not only like all of the things that were recommended in a person's survivorship care plan, but also the frequency. So it's like if it was CT scans, they would recommend like 3 to 6 CT scans in an 18-month period, for example. And when you look at the colorectal cancer, it's just a lot more involved. Like we see patients every 3 months. We are asking for scans. We're asking for colonoscopies. Whereas like, for example, in the prostate cancer group, there's no recommended scans. There's recommended medications for bone health, which is not always part of colorectal cancer survivorship, but fewer visits that I think require time off of work, prep for a colonoscopy, getting IV contrast, and all sorts of things. So I wonder if it's really just that it's harder to get complete adherence when you're asking more of people. The other thing is that there were not as many colorectal cancer survivors in this study. There was only, I think, 77, and then the other two arms were somewhere in the like mid 100s. So it's just possible that the precision for the adherence calculation is a little bit lower. And then you have to sort of ask, like, how are they measuring complete adherence? And it, like every individual participant in the trial had a slightly different plan. So they were actually, this was a lot of method, like the methodology was a lot of work on their part because they had to go through every single plan, tally up all of the things that were recommended. And then they would go into the medical record and they would ask the participants. So they would pair both like self-report and medical record to make sure that all of those things were done. So it was quite a lot of work to get all this information. It seems like it was relatively thorough, but there's always room for human error too.
Dr. Char, the thing that kind of struck me was similar to what you said in terms of the involvement. Can you talk a bit about why survivorship plans for colorectal cancer are so much more involved than, say, prostate?
It just depends on the ways in which we have observed the cancer to come back and what we know are the best methods of detecting it. So like, for example, in prostate cancer, oftentimes the PSA is a very good and very sensitive measure of when the cancer is coming back. And so you can feel very confident that a negative PSA or a low PSA means no cancer. And you can feel pretty confident that if you see it going up, it means it's come back. So that really means that you don't really need CT scans to actively monitor. We don't have such a great measure in colon cancer. So there's a CEA, but the CEA is not quite as specific as the PSA is to the prostate. A lot of things create CEA. It's naturally expressed by the cells in our gut. If you had, like, let's say a stomach flu or, enterocolitis, that would cause your CEA to go up. And so we can't really put as much reliance in that value alone.
Got it. So that then requires more reliance on imaging modalities, it sounds like.
Exactly.
And in the world of colorectal cancer, the imaging modality becomes some combination of CT scan and colonoscopy? Or how are you weighing like CT scan, colonoscopy, plus I'm going to get the test run, but the one that you take the stool sample?
Oh, Cologuard? Yeah.
Yes.
So I think of them in two separate buckets. I think of the CT scans as you're asking the question, the cancer that you already had that was removed and treated and hopefully gone forever, has that come back somewhere? Is there in the abdomen, the liver, the lungs, the places where it tends to go? The colonoscopy is asking a different question. The colonoscopy is saying, since you already got one colon or rectal cancer, you're probably at higher risk of developing a second one. So that's really looking to see if you've developed another cancer. And then we usually don't recommend Cologuard or some of those non-invasive tests because the only test that can really intervene on precancerous lesions, which are polyps, is a colonoscopy. So you can actually find the polyp. The polyp can actually risk stratify you. So if we see polyps, we want to see people get colonoscopies more frequently, and we can resect those so that those polyps do not become cancers in the future.
Got it. So can you also then talk a little bit about colonoscopy as a screening tool and colonoscopy as a surveillance tool in the survivor population?
So it is really kind of like screening. I think when we say screening, we're often thinking more in a population-based way. So we're talking about average risk people, or people who have a family history where we have no reason to suspect they would have cancer, but we're going to survey them because we want to intervene if they have one early. Whereas in the survivorship population, it is true that it's screening for a second cancer, but you're not an average risk every population person. You're a higher risk because you already have a personal history. And the other thing, which I glossed over a little bit, is that when folks have had surgeries, like to have a hemicolectomy to remove part of their colon, or for rectal cancer, they've had a lower anterior resection, where they put the gut back together again, the anastomosis, we also worry about complications there, either the cancer coming back or ulcers. And so the colonoscopy also allows direct visualization of the anastomosis.
Fascinating. Okay. All right. I see. And just out of curiosity, on average, colorectal cancer survivor has colonoscopies annually. Like the recommendation is at what
The
age?
recommendation is that after you have your tumor resected, you have a colonoscopy 1 year after that. And then the guidelines get a little bit fuzzy, but we usually say our personal practice is that you should never go more than 3 years without a colonoscopy. And then our practice tends to be that if there's something on the colonoscopy, like a polyp, that we like to repeat it in a year, to just make sure it's clean. Now, that's not specifically outlined in the NCCN guidelines or by other cancer societies, but we just tend to find that, especially for our younger patients, they're at a higher risk, and we haven't yet identified what those risk factors totally are. And so it's just better to err on being more conservative. And we really have not run into issues with insurance approving yearly colonoscopies for that population.
Can I ask you a very naive question?
Yeah.
But one that circles back actually to the pin, and I'm very happy about the fact that it circles back. But naive question. So in a colonoscopy, I'm a survivor, breast cancer, but short version is I forget the clinical word, but anemia for a while. My ferritin levels were really low. That triggered colonoscopy to rule out colon cancer. So I went through that whole protocol. They found a polyp, they removed polyp. All netted out fine. But that whole little endeavor made me go into this universe of like colon cancer screening. But what I found was that after the colonoscopy, I found that my gut was, I'm going to use the word broken, is not the right word.
It was unwell.
It was unwell. There we go. Thank you. It was pretty unwell, but I found needing to almost reset my microbiome. Because it took a long time for me to come back into a baseline that I had maintained for quite a while of just my gut feeling healthy again. So do you have any insight into like how colonoscopies and the removal of the microbiome and the replenishment of the microbiome interact with each other?
Yeah, I mean, I think this is an underexplored area. And in some ways, we know like a colonoscopy is an invasive test. It is not a benign test. And that's why there's so much care put into who we recommend colonoscopies for, right? Like otherwise, if it was not benign, or if it was completely benign, we would say everyone starting from age 10, just get it every year, like come on, line up. I mean, it's obviously expensive and resource intensive, but there's risks with every procedure that we do. And it's true that when you do the prep and you kind of are like flushing everything through, that there's a little something lost. And I personally don't know if that has really been studied to see how the composition of your microbiome changes in that kind of peri-procedural area, like immediately after the prep and then after you have your colonoscopy and you get back into it. I think that it's probably not completely wiped out, but I can imagine that it would be under stress and that the composition would change a little bit. And we don't really have great, unifying recommendations on how one should then replete or replenish, rehealthy their gut. There's so many different like probiotic and prebiotic supplements out there, and a lot of them are not regulated, and they're all very different in terms of the composition of bacteria that are in them. So it's hard to even say, like people ask, like what probiotic at CVS should I buy to really replete my microbiome? And the truth is that we just don't know. It hasn't been studied what gut bacteria are the best ones. And a lot of them only have like, I don't know, like 4 or 5, if even that. Some of them only have one bacteria in it. And the truth is that we have like thousands of millions of different species of bacteria in the gut. So it's got to be more complicated than that. I personally subscribe to the idea of just eating your healthy diet, your like fruits and vegetables, yogurt, kefir, things that have like healthy, natural probiotics in them. And hopefully that gets back to a place of health.
I love it. So you open the can of healthy diet for me, which I can't not go down. I'm sorry. Can you define healthy diet from your perspective?
Yeah, so in the colon cancer world, we think of diet in basically 2 buckets. And this is mostly just because of how it's been studied epidemiologically, but there's Western pattern diet and prudent pattern diet. And Western pattern diet is usually things that are more processed foods, heavy in red meat, sugar sweetened beverages, just a lot of the things that we would normally associate with being less healthy, hamburgers, like packaged salamis, things like that. Prudent pattern diet is more rich in fruits and vegetables, fish, more like a Mediterranean style diet, nuts, and that tends to be healthier as what we call a healthy diet. And the reason why we think of these 2 buckets is just that this is how we've sort of defined diet in a lot of epidemiologic studies that have looked at diet and colon cancer risk, or looked at diet and risk of cancer recurrence in folks with stage 3 colon cancer. And we know that a Western pattern diet does confer a higher risk of developing colon cancer, and that a healthier, prudent pattern diet is actually protective.
Very cool. I'm so excited. Yeah. Sorry, I'm such a nerd on this topic. I can't tell you how many books on nutrition and diet I read after getting my diagnosis. I don't know if you can see all the books behind me, but about 40% of those on nutrition. So I've gone like, it's hard because the data is kind of spotty and there's conflicting evidence, right? Like I've read papers that say, I'm going to pick on soy just because it's my favorite topic to pick on. Soy is protective, soy is harmful. But then when you go into the actual molecular pieces of it, now it depends on the exact molecule you're talking about. So it gets complex pretty quickly. And then there's evidence to suggest either or. All this to say that I didn't net out with a like overarching, like we know the answer, which is why I get very excited when I talk to clinicians who are ready to talk to me about nutrition. Okay, question.
Yeah, I mean, you're highlighting the challenge of nutritional epidemiology, right? That like for a long time, the studies would just pick out one thing. Like we would say, okay, like what is the association between red meat and heart disease? And you'd say, okay, well, people who eat a lot of red meat have heart disease, and people who don't eat a lot of red meat don't. But it's so much more complicated than that, right? Because if you were going to make a dietary recommendation and say, stop eating red meat because it's bad for you, well, then the question is, well, what are you replacing that with in your diet, right? Because you think of your diet as like a big pie chart. Like if you take a chunk out, you're going to fill it with something else. So if you're going to fill that red meat gap with something else that's maybe not healthy, versus if you're going to fill that with fruits and vegetables, like those are going to be very different health outcomes. And so then we've learned over time that it's really more about dietary pattern than it is about specific foods. And that's sort of where the field is moving. There's all sorts of different dietary patterns that people are studying. So prudent pattern and Western pattern diet is one, but there's also these dietary patterns, one of which I'm actually looking at in colon cancer patients, which is an inflammatory dietary potential. And these are actually like statistically derived. Like it's not like I said, like a nutritionist sat down and said, well, like this food seems healthy, this one doesn't. Let's see how it pans out. They literally looked at people who had had food frequency questionnaires filled out every other year in the Nurses' Health Study, which is like this huge cohort of prospectively obtained data. And they looked at everybody who had then gone on to develop colon cancer or gone on to develop heart disease, you name it. And they would look at their diets and say statistically what foods correspond with more inflammation using their like serum inflammatory markers. And then does that correspond with getting a disease? And so it turns out that they can build these inflammatory dietary potentials where you look at like 12 foods and it predict if that diet is going to lead to generalized inflammation in your body, and then take that and correspond it to health outcomes. And so in the Nurses' Health Study, folks who have had a higher inflammatory diet potential based on this score had a higher risk of developing colorectal cancer.
Huh.
But what's tricky is that like when you look at the score, it's not like a dietary recommendation you would make to somebody. It's not like, eat 3 servings of this, eat 2 servings of this. It's sort of like a signal towards something that we then have to explore in a way that's actually going to be translatable to population health and translatable to a person who's sitting in your clinic and needs a recommendation.
Question for you. So when you say dietary pattern, and so it's almost like a statistical, sorry, I'm going to use all the wrong words, because it's over time, many years, self-reported, right? So there's also margins of errors, but then you have a biological component in terms of the marker. How do you balance something like that versus macros?
Macros like your carbs and proteins and things like that.
Yeah, only because the question that we ended up with, right, was like initially it was like red meat, cardiovascular risk, but then the question comes down to like if we are taking this more of a statistical approach to it, it's a pattern over time. It's almost like we're looking at it from a cumulative risk perspective, presumably. How do we then compare that to just like macros? Because even just pure macros, regardless of the source of the protein, I'm just going to pick on protein, regardless of source of protein, even the macro composition and the split, from my very naive understanding, also matters in terms of risk profile. So like, how do you balance those 2 things out?
Yeah, I mean, that's like its own little question, right? Like among one food frequency questionnaire that a person fills out or that a whole cohort of people fill out, you could ask the question of what proportion of macros is going to be the healthiest in terms of whatever health outcome it could be. It could be what pattern of eating like 10 specific foods could be the healthiest. There's a lot of different ways that you can sort of slice and dice it. So I think the macros is also an important question. I personally don't know the data on that. I haven't looked into it, but that is a natural progression from the don't eat red meat to what are you eating instead of it. There are these like substitution models where you basically say like what people who eat less red meat, but also holding carbs constant, holding, like unsaturated fat constant, holding other healthy things that we want constant. What is the difference in risk of colon cancer, let's say. And then what you're really saying is like, well, what is the difference in saturated fat intake? Like, for example. But that's one way that people have thought about approaching it.
It's hard. Okay. So
it's challenging. It's super challenging.
So I imagine you get this question all the time. So I'm going to pretend I'm a colorectal cancer survivor in your clinic. Dr. Char, I'm done with active treatment. What in the world do I eat?
So I usually recommend basically this prudent pattern diet. I'd say to eat fruits and vegetables, to limit red meat, to limit sugar sweetened beverages, to focus on healthier sources of protein like fish. Vegetarian is nice, but not necessary. And to avoid fad diets. I think there's a lot of different stuff on the internet about like keeping really keto or paleo. And the truth is that we don't really know that those things are beneficial and they can be really challenging. And, people have gone through surgeries and radiation and chemo. And like, if you think that a colonoscopy is messing with your gut microbiome, it's like, then add all these other things on top of it. And so there's also just a huge component of like eating what you can and eating what's not going to bother your gut. So like, it's nice to say you're going to eat a lot of broccoli, but if a lot of broccoli is giving you tons of gas and making it impossible for you to live your life, then like, that's not the right choice.
Interesting. So it's almost like a mix of like, generally speaking, eat these like relatively healthy food categories, and then almost a little bit of like monitor your body and
Yeah,
self-adjust.
exactly.
Interesting. And what about like body composition? Because I'll give you the other little like rabbit hole I went down. More breast cancer, to my knowledge, than colorectal cancer. But in the world of breast cancer, especially if you have hormone positive breast cancer and the cancer was or is hormone driven, there is all this like stuff around like strength training and resistance training and muscle mass and body composition. Again, very nascent, kind of understudied, spotty data, so hard to make deterministic kind of answers. But anything in there for colorectal cancer patients?
I mean, for the exercise component, our general recommendation is 150 minutes of sort of moderate intensity exercise, gets your heart going in a week. So that can be 5 sessions of 30 minutes, you name it. And it's nice to have a mix of both resistance and aerobic exercise. But then, exercise with a specific body composition goal, I think we just don't know the answer to that. It's not like you're doing it with the goal of developing more lean mass. I think all we know really is that exercise in and of itself is protective and helpful. But there is a lot of questions still in the field about obesity and like having increased adiposity and what that entails for outcomes after treatment for colon cancer. The truth is that we don't really know. The data is a little bit mixed on whether having obesity after your diagnosis is going to increase your risk of the colon cancer coming back or of dying of colon cancer. But a lot of our patients also ask us about like GLP-1 agonists, which are huge now. And like, should I be on it? Should I not be on it? Is that going to be protective for my colon cancer? The truth is we don't know specifically if it's protective against colon cancer, but we also have no reason to suspect that it would be bad in terms of your colon cancer outcomes. And so we have a lot of patients who pursue those as well.
Dr. Char, you just went to where I was going to go. Okay. Now you have to answer my GLP-1 question. I'm sorry. So GLP-1s, one of the side effects though is GI issues, right?
Yeah.
Of being on the drug. So if you're a CRC patient, happen to have a comorbidity, either obesity and or diabetes, or some sort of cardiometabolic issue, PCP and or oncologist blesses GLP-1 use, but you are a colorectal cancer patient. How do you work on the GI issues as a side effect of the drug? Because that feels like it's like, oh, okay, now we have an entire can of worms that have opened up.
Yeah, so that's super challenging, right? And with the GLP-1 agonists, there's a little bit of predictability with the GI side effects. So, from what I've heard from folks is that it's usually like that when you get it right at the beginning is when sort of the GI symptoms are the worst, and then it sort of wanes as you approach your next dose, and then it gets bad again. And then as you're doing your dose ramp up for the GLP-1 agonist, people get kind of used to a certain dose. And then when they move up to the next dose, that's when they experience more side effects. And some people really just don't make it all the way up the dose escalation ladder, and that's okay. But usually the reason they don't is because of GI side effects. So there's a little bit of predictability in that. I think that it's always fine for folks to try it and then decide that they don't think that it's going to be working for their quality of life. So I would say if you were coming to me and you already had really significant issues with alternating diarrhea, constipation, abdominal cramping, I'd say you really should know that a GLP-1 agonist would potentially exacerbate those and make it more challenging. And maybe that's just not going to be worth it. But others, I think, might say, well, it's worth the trade-off for my other obesity and health-related goals to try the GLP-1 agonist. I think, fortunately, when you come off of the medicine, the GI-related side effects go away. And so at least there is a way out if it doesn't go well.
Dr. Char, so going back, actually, I'm going to go circle back to survivorship care plans for a second, because there's something that the GLP-1 conversation kind of triggered, right? Because if you're a survivor, you're post-treatment, presumably you're talking to your PCP, your oncologist, you kind of now still have a multidisciplinary care team. So for something like this, where you're a cancer survivor, but you're on a GLP-1, who's your default go-to? Is it the PCP or the oncologist? Because it feels, especially in this use case, kind of, if I'm a patient, it's a little bit of a, who do I call?
Yeah. So, I mean, usually for the prescription of the GLP-1 agonist and the management of whatever the goals are that it was prescribed for, that would fall under the purview of the primary care doctor or an endocrinologist, depending on who it is. And then I think for symptom management, it's a little bit in the hands of the patient to say, well, okay, I just got my shot yesterday and I think this is like my classic GLP-1 cramping and I'm having an issue. I'm going to call my primary care doctor, but they're also always welcome to call us. And I would say if anything ever feels unusual or feels abnormal, that patients should not hesitate to reach out to us and we can sort of help to think through it together.
Can I ask you a follow-up on that? Because one of the kind of almost like rules of thumb we have on the meta side is a new symptom that is persistent and or worsening is kind of the generalized trigger for calling the oncologist. Is that true for colorectal cancer patients too?
Yeah, I mean, there's specific things we counsel on too. So blood in the stool is never normal. If people presented like with anemia, with a low ferritin, and sometimes that can present with like low exercise capacity, shortness of breath, like those are things we want to know. Fevers, we always, want to know about. But in the survivorship space, it's sort of like unintentional weight loss. It could be a whole host of things, GI bleeding, new constipation that is really just difficult to manage, any changes in the bowels that feel just not right and not consistent.
Dr. Char, I'm looking at the clock and we're almost at time. We've covered so much more than I thought we were going to cover, so I really appreciate you diving in to my many rabbit holes. Question for you, anything that we haven't covered that you'd like to talk about?
I don't know. I mean, I think I came into this thinking a lot about survivorship care, and I was thinking about like this study, how the measure in this study was basically, do you prescribe to everything on the checklist? Like, did you check all the boxes, get all your scans, get all your labs? And I think, that's that was perfect outcome for this type of study. But I think that survivorship care is so much more than just, did you get all the things on the checklist? And I think one of the things we hadn't really talked about is that in that transition from active care to the survivorship, it's a huge mental shift. I think like patients come in to see when they're on chemotherapy, we see them almost as often as every 2 weeks. And they're coming into the clinic even more than that for scans and to see other providers and a whole host of other things. It's really like a very all-consuming period. And then it ends. And then we say, well, in colon cancer, we say, we'll see you again in 3 months. And that's a huge period of time to just sit with everything that has happened, the physical consequences, like the financial consequences, the ways that it impacts your mental health, your sexual health, everything. And also the fear of recurrence. You're sitting there not knowing if your cancer has come back and we're saying we're not going to see you back until 3 months. So that can be really challenging. I would say people experience it really differently. Some patients are like, see ya. I don't want to ever see Dana-Farber again. And if you make me, I'll come back in 3 months. But for a lot of people, it's like there's a sense of security in being seen so often and a little bit of a sense of, oh no, when we don't see people. And that can go on. I mean, we have patients who make it to the 5-year mark where we really feel like confident that that person has been cured, that the risk of that cancer coming back is so incredibly small. And there's still like this, oh, like, am I on my own now? And no one's ever on their own. We're always available, but it's a challenging, I think, mental shift from kind of the go, go, go to like, now what?
I very much appreciate you pulling that back in because I think that's a very accurate description. And I imagine it's the same kind of across cancer types because I very much relate to what you just said. I think for me, the emotional part that was the hardest was when my port came out.
Really?
That was the hardest. I mean, I had triple positive breast cancer, so I was in infusion treatment for 18 months, and because I was on Herceptin for a long time. And there is this like weird, like it almost feels. I'm going to use an extreme example and then back off a little bit, but it almost feels like you're pushed over the edge off a cliff, and you're in free fall, because up until then you were on this edge, but the care team was like holding you back almost. Yeah. And now all of a sudden the care team is like, yeah, we're done. And you're just in free fall. And you're like, oh my God, am I going to survive this or not? And it was such a weird feeling for me because up until then, I didn't have the, I'm going to die from this. That was the weird part for me. It was like, I didn't have the, I'm going to die from this. Post port coming out was when all of my fear kicked in. And
why do you think it was tied to the port?
I think for me, because I got NED call because I had neoadjuvant chemo, lumpectomy, radiation, a year of Herceptin. and then this like decade into the future for hormone therapy, right? So, but I
Right.
got the NED call at lumpectomy. So, from a timing perspective, I was quote unquote cancer free like 3 months into treatment, 4 months into
Yeah.
treatment. But
Wow.
then I had this year of treatment left, which meant for a full year, I was back in the clinic, back in infusion chair, getting side effects every week, every third weekend, being super sick. So I never really thought it was over until pork came out. Pork coming out meant it was over for me.
Yeah.
And that was such a hard moment because also support gets aggregated at the beginning of the experience. But everybody shows up, everyone is like, oh my God, we're here for you. So all the support also gets concentrated. But if you're in treatment for a long duration of time, support also starts waning.
Mm.
So I think isolation actually builds as time goes on. And I think you described it as go, right? I described it as blinders are on when you're in treatment.
Yeah.
And when you're done, the blinders come off. So
Yeah.
you're like, oh shit, what just happened? So I do think there is this like fairly significant mental health. I'm going to use the word crisis. I don't think it's a crisis, but there is this mental health acuity point at that transition period that I think is hard. But
Yeah.
I don't think therapists, honestly, I don't think therapists or traditional CBT is sort of. I don't think it's the right tool
Right.
because I don't think it's not designed for that. It's not
Right.
designed for that. Like you just want something really real, and it's not PTSD yet because you're not really in the trauma mode yet. You kind of haven't come to grapple with it. So I do think about it a lot for what it's worth.
No, I mean, it's totally true that it is a need that is not addressed by traditional CBT that we think about for anxiety. Like it's not generalized anxiety. It's a fear of cancer recurrence.
Yes.
It's a very different experience. And there are psycho-oncologists, and we're very fortunate to have some at Dana-Farber that we work with who are really trained in that specific need, but there's just not enough of them, right? It would be amazing if we could have a psycho-oncologist just, speak with every single one of our patients, specifically around that fear of cancer recurrence and its manifestations, the way that it impacts insomnia, the way that it impacts fatigue. And if you already do have underlying depression, anxiety, the way that it impacts those, it's a very unique need.
You're completely right. I was very fortunate to have a psycho-oncologist and it really helped. It really, really helped. But it took a while to get in front of them because there's such a backlog as well, right? Even for the
Right.
psycho-oncologists that are available, they just had this massive wait list. And then you have to be privileged enough to be on a PPO plan and like pick your flavor of like insurance privilege. But
Right.
you're completely right. I think there is just this, you said something right now that like really struck me. Uh, Fatigue is an interesting one, right? Because the fatigue is so real, but then there's this fatigue that is like, is it late effects of treatment? Is it fatigue from ongoing maintenance treatment? Is
Mm-hmm.
it fatigue from it's a new symptom of a new thing happening? And then is it fatigue from a psychological perspective? So
Mm-hmm.
fatigue for me is such it's one of those like super complex symptoms that from a patient perspective becomes very hard to communicate with your oncologist
Mm-hmm.
or your PCP. And it's one that's very easy to be quote unquote dismissed
Mm-hmm.
because it could very much be late effects of like the oncologist is like rationalizing it and you're like, okay, all right, the odds of it being this or that, and like you go through that kind of like triage protocol almost as to whether
Yeah.
this is like something that I should escalate or not, or is this psychosomatic. But from a patient perspective, it's so hard to figure out which of those four things it is.
Yeah. And even more, it could just be the interaction of all those things too. Fatigue's a really challenging one. I would say like, I know a psycho-oncologist and we were talking about this recently actually. And he was telling me that like insomnia is in some ways, you can move the needle on it better than you can with fatigue. So even if in folks who have insomnia and the insomnia gets better and is treated, there's still ongoing fatigue. Like they're not necessarily tied together because it is so multifactorial. And fatigue is also, it's an experience. It's not like an objective, like I slept this many hours last night, right? And so it's not, it's your experience of fatigue and also how much it's impacting your life. So you may feel fatigued all the time, but how much it's actually getting in the way of you doing things can vary over time as well. And there's different scales that sort of capture that, but it's a challenging one. And I think it makes sense that it's hard to bring up to providers, because as a provider, it's like, I don't know how to move the needle on that either. It's super challenging.
Yeah, it's one of the things that I think about a lot, because I think it's one of the things that our community faces quite a bit, and personally have faced it God knows how many times, and had very different protocols activated. And that's the amazing part, right? Because fatigue could be your iron is low. And it took
Yes.
like 3 visits to get there. And I was like, oh my God, I'm so glad I kept pushing, because it turned out that I needed like iron infusions.
Wow.
Right. So it's like, but on the other hand, it's like fatigue could just be like, you worked hard for like, I don't know, 4 months and now you're just exhausted. Right. So it's
right. Yeah. I think the things that you can easily check and rule out should be checked and ruled out before people jump to like, things that you can't really prove. But you had mentioned something, I don't know if we have time to get into it, but you had mentioned how the resources felt very concentrated at the beginning of your cancer care and sort of weaned at the time that you felt like you perhaps needed it the most. And I'm curious to hear from you what you think would have made a difference. Like, what was the one or few resources that you really wished were available to you?
I'm going to answer your question, but I need the audience to know I'm not self-promoting it. So I describe cancer like a treacherous hike, where you don't get access to a map, you don't get access to gear, and you don't get access to a guide. And when I was saying resources wane, it's the gear and guide start waning. But the real issue is you don't have a map. You can't really predict out what's happening, right? So like if I had known that I was going to be, if I had really known, like I am sure my oncologist told me during treatment planning that I was going to have 12 rounds of infusion. I am sure of it. But there's so much information coming at you that it's very hard for you to really understand that it's actually going to be 18 months of treatment. So if I had a tool or a map, know that like, you know what, here are the branch points. It's not predictive. We don't know everything yet, but here are the next 5 steps roughly. We're going to get to the station and there's like 3 roads we can take. These different roads are different durations of time, different durations of intensity, different types of treatments. And if I could like actually see that and absorb it and use that to communicate with my family, I could have requested support further out into treatment. Right? I could have planned my life a little differently. I could have asked for time off differently. Because I mean, I'm AYA, right? I was 30 when I got diagnosed. So like I was working full time. So like even like when you take PTO, when you not take PTO, you only have certain amounts of PTO. Yes, you can take medical leave, but do you do FMLA? That's also time box. Do you do short-term disability? Time box, right? So like all of that stuff is moving parts. But if I had a little bit of predictability, I think that would have made a huge difference. And the reason I was like, I don't want anybody to think it's us promoting our product, it's because that is the predictability. It's a little
I set you up perfectly.
So I really wish. And
well,
honestly,
that's awesome.
That's my goal, right? I want to make sure patients get maps, because I think giving back control to patients is so important, because it allows us to, I really believe it allows patients to influence the overall quality of life, because I think it's hard for clinicians to take on the full burden of it, right? Because some of the psychosocial stuff I should be able to find myself if I know it's about to happen, right? I may have a church community that I can rely on or talk to. I may have other resources that the system may not be providing me, but it's more of like the foresight that here are the things that may come along the way.
Well, I think what's so powerful too about a map like that being designed by someone who's experienced it, because it really like only someone who has gone through it can know what the signposts that are most helpful would be and when to receive them. So that's awesome.
Thank you. And we do it with oncologists, by the way, because it has to be clinician and evidence. So
that's great.
I appreciate it. Dr. Char, this has been such a pleasure. I cannot tell you how much I have loved our episode. I'm walking away having learned so much from you. So I appreciate you entertaining the 15 different topics we covered.
Oh, I loved it. Really appreciate you having me on. It was a great conversation.
Thank you, Dr. Char. We have to do part 2 if you're up for it at some point.
Would
So
love
I'd
to.
love to keep up to date on the many bodies of research, especially in the nutrition side. So
Would love to.
awesome.
All right.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.